Burn patients require massive amounts of nutrition for healing. Feeding begins as soon as the gut is working, usually by day 1, and supplements are frequently used. Patients are weighed frequently, and pre-albumins, which are a marker for nutritional status and malnutrition, are drawn frequently to monitor nutritional status. If burns are greater than 25% of total body surface area, the patient often requires tube feedings and glutamine, which is an amino acid that maintains lean muscle mass. Vitamin C is also necessary for collagen formation and also is an antioxidant, and it helps facilitate epithelial cell regrowth. Oxandrolone is an anabolic steroid to maintain lean muscle mass, thus it helps with weight gain. And Marinol, which is an appetite stimulant, helps give them essentially the munchies. All limbs should be placed in a functional position, and the functional position is not necessarily the comfortable position for the patient. It takes about 20 minutes for a contracture to form, so special care is taken for joints in particular. Patients with neck burns should never have a pillow. Axilla burns should be at a minimum 75-degree angle, preferably 90 degrees, and ankles should be at a 90-degree angle, and knees and elbows should be kept straight. So what is a minor burn? A minor burn is less than 15% total body surface area burn on an adult that is less than 40 years of age, 10% in an adult over 40, less than 10% total body surface area in children that are under the age of 10, and less than 2% of total body surface area, full thickness burn, and no cosmetic or functional risk to the face, eyes, ears, hands, feet, or perineum. Initial treatment is typically in the ER, then they go home. However, eye burns will require erythromycin and special treatment. Goal is to stop the burning, so cool water or soaks, prevent infection, so sterile dressings and silver sulfadiazine, pain management with Tylenol, check the tetanus immunization status, and wound care is done by outpatient management. Moderate burns are deemed as 15 to 25% total body surface area burn in an adult less than 40 years of age, 10 to 20% in those that are over 40, also 10 to 20% in children less than 10 years of age, and less than 10% total body surface area full thickness burn without cosmetic or functional risk to the face, eyes, ears, hands, feet, or perineum. These burns are managed in the hospital setting. Major burns are 25% total body surface area in adults that are less than 40 years of age, and 20% in adults over 40, as well as children under the age of 10. They require emergent treatment in the emergency department following the ABCs. Prompt contact with the burn center must be initiated, and apply a sterile sheet or blanket and transfer to a specialized burns care facility as soon as possible. No topical treatment until reaching a primary burn center. Goals are to save lives, maintain and protect the airway, restore hemodynamic stability, and replacement of missing skin later, as well as the healing process and correcting any complications that occur in the following days. So the phases of treatment, so essentially we're going to be bringing it all together. We have the resuscitative phase, which is the emergent phase, and this is the first 24 to 48 hours after a burn. We want to secure and monitor the airway, and this is where escharotomies or fasciotomies may be needed. We want to stop the burning process, so flushing if a chemical burn, assess the burn injury, and evaluate the mechanism of injury. And of course, administer fluids. Crystalloids, so isotonics or hypertonics, usually LR or 5% LR in pediatric patients. And later on, after the first 24 hours, colloids can be administered, so albumin. Chest x-ray and film should be obtained for all clients with extensive burns. We want to minimize pain with analgesics, IV route only, frequent small doses. They could be repeated every 5 to 10 minutes, usually morphine sulfate or fentanyl, never IM or sub-Q. We want to prevent infection, so careful wound care. Initially, when burning process is stopped, we want to remove the clothing and cover with dry sheet and blanket. Shave hair from around the burn area to prevent further contamination of the wound and to promote wound healing. Maintain body temperature and provide emotional support to the patient and the family members. Chemical burns need to be irrigated continually for 20 minutes. In patients with 20 to 25% of total body surface area, insert an NG tube to prevent aspiration related to ileus, and consider tetanus if it cannot be confirmed that they have had a tetanus within the last 5 years. And some of your resources say within the last year, so bear that in mind. In the acute phase, which is approximately 48 to 72 hours post-burn, it begins when the client is hemodynamically stable, capillary integrity is restored, and diuresis has begun. Acute phase continues until the wound closure is achieved, and we manage the treatment of the burn wound in this phase. Infection control is a major component. We want to minimize transmission of microorganisms, so gloves, caps, masks, shoe covers, scrub clothes, plastic aprons. We may limit visitors, any sick staff or family prevented from having contact with the client. We want to avoid any complications, prompt detection, and prompt management of complications should they occur. We want to continue to monitor labs, so CBC, BUN, electrolytes, wound cultures, etc. We want to minimize pain to the patient, and we want to maximize function of the limbs. And monitor graft site and graft adherence. Metabolic demands continue to occur. Basal metabolic rates are 40 to 100% higher than normal levels, thus adequate nutrients needed, so we need to increase the calories and protein. And there is a chart in Black and Hawk for calculation of nutritional support. Activity is encouraged as soon as possible, although we do still want to protect the grafts. Range of motion can be done on day 1 on hands, feet, neck, shoulders, axilla, and any joints. Ambulation to maintain strength and range of motion, and splints to maintain proper joint position and prevent contractures. Medications that need to be reviewed by you are analgesics, anti-ulcer medications, topical antimicrobials, and pre-existing medical needs of our patients. So think about the major conditions of the elderly or the young that may require additional medications. We need to bear in mind the psychosocial needs of the family as well as the patient. And the longest period of adjustment occurs during the acute phase. There's a variety of emotional and psychological responses that will be noted in our patients. The meaning of what has happened is sinking in or being processed. It's very important to educate throughout treatments and prepare for what to expect down the road, and be honest with the patients. We still want to continue to assess respiratory status, pain, nutrition, ulceration, mobility, contractures, psychological adjustment of both the client and the family throughout the acute phase.